Hello friends, welcome to the Tutor Med channel where everything medicine is simplified. My name is Dr. Obeng-Frimpong, a medical practitioner with keen interest in medical education. In today's episode, we will discuss the management of sepsis and septic shock. Although it is going to be a relatively long lecture, this will be a very simplified and comprehensive piece, and so I recommend you watch the video till the end. And if you are new here, you want to consider subscribing and hit your notification bell so you can be notified when new videos are uploaded. Alright friends, let's begin. And so this is going to be the outline for our presentation. We will have an introduction, primarily dealing with why sepsis is a problem. And then we will see a case presentation on a patient with sepsis. Now, the definitions of sepsis has evolved over the years, and so we will look at the evolution of the definition of sepsis. Then we will see a brief but comprehensive pathophysiology of sepsis. Then we will look at the clinical manifestations of sepsis. Move on to the relevant investigations and the approach to diagnosis of sepsis. And then lastly, we will take a look at the approach to management. By way of introduction, let's look at the problem. Why is sepsis a problem? We will give the current definition of sepsis later in this video, but in a crude way, sepsis can be seen as an infection with a high mortality. In other words, a fatal infection. Now, the first reason why this condition is a problem is that the severity of sepsis appears to be increasing despite advancements in medical technology. And so, although we are making great strides in making medical care more sophisticated than before, sepsis is still overpowering the medical community. And this is according to a study done by Martin et al. In 2007. Again, sepsis is not a problem only with the internal medicine department. Every medical discipline encounters this menace. In pediatrics, surgery, the dental unit, obstetrics and gynecology, ENT, etc. The only discipline which may not probably be bothered is the radiology department, as sepsis is a headache for everybody. The third challenge is that among the various types of shocks, or shock if you will, that is hypovolemic shock, cardiogenic shock, neurogenic shock, etc., septic shock is the most common cause of death among hospitalized patients. So among patients who have been admitted, a septic shock is the most common cause of death. And so this also poses a problem and the need, or for which reason we need to understand sepsis and its complications. And so, still on the problem of sepsis, according to the third and most current international consensus definition for sepsis, which is also known as sepsis 3, data shows that a patient diagnosed with sepsis alone has a mortality higher than patients diagnosed with myocardial infarction, stroke, and even trauma-related injury. This means sepsis by definition is severe, and so there is no need to say severe sepsis. Once the diagnosis of sepsis is made, the patient and the clinician are in trouble, as there is about 10 to 40% chance of mortality. Now, a patient with sepsis can go on to have septic shock, and comparing them with those with just sepsis, a patient with septic shock has at least 40% chance of dying, a greater chance of dying. So you see, If despite the medical advancement in technology, developed countries like US, UK, France, etc. are coming up with this data, then you can imagine the magnitude of the problem in developing countries like Ghana. And so there is a need to study sepsis and know how to recognize it early, because early recognition, timely and appropriate measures can go a long way to winning the battle against sepsis. Now, having introduced the topic, let's look at our case presentation. And so she is Mrs. A.N., a 26-year-old female or woman. She was a breastfeeding mother who had delivered her baby about 10 weeks prior to presentation via an uncomplicated spontaneous vaginal delivery, SVD, and was not known to have any chronic medical condition. She presented with a 3-day history of fever, vomiting, and a painful left breast. This was associated with chills, rigors, anorexia, and malaise. And so when symptoms over the 3-day period did not improve on some over-the-counter medications she got from a local pharmacy, she reported to the facility for evaluation and expert management. Now at this point, it was very obvious she had something going on in her left breast which could explain the constitutional symptoms she was having. But on direct questioning to make sure that these constitutional symptoms were not from other body sites but from the suspected breast pathology, we found out that there was no history of dysuria, increased urinary frequency, urgency, or unusually foul smelling urine. These important negatives made a possible UTI unlikely. There was no history of myalgia or bitter taste, and this made malaria also unlikely per the history, although it is possible. There was no history of an antecedent offensive vaginal discharge, lower abdominal pain, a previous diagnosis of STI or poorly treated STI in the past, and here we sought to rule out a possible PID or a pelvic inflammatory disease like endometritis. There were no coryzal symptoms, pleuritic chest pain, or cough productive of sputum, and so that made a chest infection or pneumonia also unlikely in this patient. Now, although she had intermittent headaches, she had no associated photophobia or neck stiffness. She had not traveled recently to the meningitis belt of the country and had not been in contact with any person showing symptoms suggestive of meningitis. The rest of the history offered no diagnostic information. And so at presentation, her vital signs were as follows. She had a temperature of 39.2 degrees Celsius. She had a respiratory rate of 24 cycles per minute, a blood pressure of 95/64 millimeters of mercury, which gave a mean arterial pressure or MAP of 70 millimeters of mercury. Then she had a pulse rate of 105 beats per minute. It was regular and of good volume. Then she had an oxygen saturation on room air of 97%. And so please take note of these values, as we will need them when justifying the diagnosis of sepsis for this woman in our literature review later in this video. And so on examination, she looked acutely unwell and was in some respiratory distress. She was mildly pale, anecteric, febrile, and she had warm extremities. The capillary refill time was less than 2 seconds. She weighed 62 kilograms, and the respiratory and cardiovascular examination findings were clinically unremarkable, except for the tachycardia, tachypnea, and hypotension, which were mentioned before. The abdominal exam was clinically unremarkable. Neurological system was grossly intact, with the Glasgow Coma Scale, a GCS of 15 out of 15. Now, on examination of her breasts, there was an obvious asymmetry between the right and the left breasts. The left breast looked bigger than the right. The left outer upper quadrant looked swollen, erythematous or reddened, and then there were no other skin changes. There was tenderness and differential warmth. There were no masses palpable in both breasts, but there were tender left axillary lymph nodes, all of them with benign features. And so, after the clinical data, we needed to make a clinical diagnosis. And so, a diagnosis of sepsis secondary to left mastitis, rule out left breast abscess, was made. And so the patient was admitted by the ER team. Blood samples were taken for full blood count, blood culture or blood for culture and sensitivity, and then blood film for malaria parasites, BUE creatinine, urine RE, and urine CS. And the patient was started on IV clindamycin 300 milligrams QID, meaning 4 times daily, and was given IV paracetamol 1 gram TDS or 1 gram 3 times a day. In addition, she was given IV normal saline 3 liters in 24 hours as maintenance fluid, and then a urethral catheter was passed to monitor her urine output. She was then sent to RED for continuous monitoring and vital checks. And so later that day, the full blood count came, and the picture showed an HB of 9.9 gram per deciliter with an MCV of 74, which was low, and an MCHC of 25, which was equally low. And so this red cell picture indicated that the patient had a moderate microcytic hypochromic anemia. Please check on our lecture on the full blood count if you are not familiar with full blood count interpretation. The white cell count was 21 times 10 to the power 9. And then there was a differential neutrophilia, meaning that the neutrophils were very elevated. The platelet count was 450 times 10 to the power 9. The upper limit is 400, and so this patient had an elevated platelet count. known as thrombocytosis. And so to summarize her full blood count report, she had a moderate microcytic hypochromic anemia, leukocytosis with differential neutrophilia, and then thrombocytosis. And then later in the day as well, the blood film comment for malaria parasites came out negative. And so the full blood count agreed with the fact that this patient has an infection going on. And so on admission day 1 at Red, she still complained of a painful left breast and a fever. She still looked unwell. She was mildly pale, anicteric. The left breast exam findings had not changed that much compared to when she came. The urethral catheter had drained about 0.5 ml per kg per hour of amber urine. And then the vitals that morning showed a BP of 88 on 62 millimeters of mercury. This BP gave a map of 63 millimeters of mercury and then a pulse of 97 beats per minute and a temperature of 37.2. So the temperature had come down from 39.2 to 37.2. And so the plan was to change the dosage of the clindamycin from 300 QID to 600 TDS. And so we did IV clindamycin 600 TDS, and then we added IV rosafin 2 grams BD or 2 grams twice a day. We continued the IV paracetamol 1 gram TDS, and we gave an instruction to start IV noradrenaline perfusion at 20 ml per kg per hour to keep the MAP above 65 millimeters of mercury, since she had a MAP of 63. Kept the urethral catheter in situ for urine output monitoring like we did. Then we started subcutaneous Clexane 40 milligrams daily for thromboprophylaxis. Then she was to do a breast ultrasound scan when hemodynamically stable, and to retrieve the results of the outstanding labs, the BUE creatinine, blood culture, urine RE, urine CS, and other labs. Admission day 2, still on the red ward. This time, she complained of pain, but it was mild, and there was no fever compared to the presentation day and then the admission day 1. This time, she looked relatively better. She was mildly pale, still anicteric. The left breast swelling had reduced, and there was not much differential warmth. There was still mild tenderness anyway. The urine output was normal. And then the blood pressure without the vasopressor support was now 100 on 65 millimeters of mercury. The vital signs were normal, and she had unremarkable physical exam findings. Now the BUE creatinine and the urine RE results had come, and they were unremarkable. The blood culture and sensitivity report was still not available, and so the plan was to continue the maintenance IV fluids, continue the antibiotics, the IV paracetamol, and then the subcutaneous Clexane. Because the temperature had normalized, we added iron-containing hematinics for her microcytic hypochromic anemia and removed the urethral catheter. Then we asked her to do the breast ultrasound scan. She was then transferred out to the female medical ward. And so on admission day 3, this time on the female medical ward, there were no complaints. All physical examination findings were clinically unremarkable. The breast ultrasound scan done showed no breast abscesses. The blood culture results had come, and after 72 hours was negative. The repeat full blood count was normal, except for the moderate microcytic hypochromic anemia. So based on this, the patient was discharged on TAB antibiotics. We gave clindamycin and enkephazyme, and then discharged on the TAB hematinics, and was to come for review the following week. Alright friends, now let's take a look at the evolution of the definition of sepsis and septic shock. Currently, the battle is between the old criteria or model called SES and a new model called qSOFA score. Well, let's not be in a haste to hear their banter. Let's take some time to see how they evolved. And so, as stated earlier, the definitions of sepsis and septic shock have rapidly evolved since the early 1990s. There have been 3 international consensus conferences in the quest to get a sensitive and a specific definition for sepsis. And so there have been 3 meetings. That is what I want to say. The first meeting was held in 1991, and that was Sepsis 1. The second meeting was 10 years after, and so it was held in 2001. That is Sepsis 2. And the third meeting was held between the years 2014 to 2016. That was the third meeting, Sepsis 3. And so the definitions which came from Sepsis 1 and 2, that is the 1991 definition and the 2001 definitions, were pretty much the same. Here, what you needed was an evidence of a focus of infection, like in our case presentation, an evidence of mastitis, a breast infection, plus at least 2 parameters of the SIRS criteria. Now, what is SIRS? S-I-R-S. SIRS stands for Systemic Inflammatory Response Syndrome, and it is a widespread or a generalized host immune response to any trigger of inflammation. And as you remember from pathology, the trigger of inflammation can be an infectious trigger or a non-infectious trigger. And so already you are seeing the pitfall here, right? That non-infectious causes can also trigger a systemic inflammatory response. And so SIRS is not specific only for infections. And so this is one big pitfall. But then this pitfall is just one of the problems. We will see the other problems in subsequent slides. Now, we said you need an evidence of infection focus plus at least 2 parameters of the SIRS criteria. And so what are the parameters of the SIRS criteria? There are 4 parameters in the criteria as shown by this picture. The first parameter is temperature, and you need a temperature either less than 36 degrees Celsius or more than 38 degrees Celsius. That's a score of 1. Then a heart rate more than 90 beats per minute. Tachypnea or respiratory rate more than 20 cycles per minute, or someone with a partial pressure of carbon dioxide less than 32 millimeters of mercury. And then you needed a white blood cell count of either less than 4,000 millimeters cube or a white cell count more than 12,000 millimeters cube. Or still on the white cells, if the number of immature white cells, which are called bands, are more than 10% of the total. Then, if you have 2 of these parameters positive, you can diagnose, plus an evidence of infection, you can diagnose sepsis. And so, let's use our patient. For our patient, she had a temperature of 39.2, which was more than a 38, a heart rate of 102 beats per minute, which was more than the 90, a respiratory rate of 24 cycles per minute, which was more than the 20. And so, using the SES criteria, our patient fits into the definition. Now, on the red side of this picture gives the idea of how the SES model categorized the spectrum of events in sepsis. And so we said that a patient has sepsis if there was SES plus a presumed or confirmed infection, and it was followed by severe sepsis, which is a patient with sepsis with an evidence of organ dysfunction, like an acute kidney injury evidenced by increased creatinine or decreased urine output, liver injury evidenced by deranged liver enzymes or increased bilirubin, etc. Then this was followed by septic shock, and per the old model, septic shock was defined as severe sepsis plus a refractory hypotension. Now, refractory hypotension means that you have a low BP. Usually, when a patient has a low BP, when they give the patient IV fluids, the low BP should respond to the IV fluids. But refractory hypotension means that you have a low BP which is not responsive to initial fluid resuscitation. Then the last on the spectrum was multiple organ dysfunction syndrome. And here you needed an evidence of more than 2 or 2 or more organs failing. However, like we saw in our introduction, sepsis has a mortality greater than myocardial infarction, stroke, and trauma-related injuries, making sepsis inherently severe. And so, by definition, sepsis is severe, and there is no need to entertain an entity called severe sepsis. And so, this is one parameter or one of the concepts in the SES criteria, which was done away with, that we don't have anything called severe sepsis. And so, the SES criteria or model had been used for a little over 20 years since its birth until the year 2016. And so, why the criteria changed? Why did the new model qSOFA score overpower the SES model, murdered it, and built a grave tomb for SES 1992 to 2016? Why did the medical community see the need to allow qSOFA to bury SES? That is our next discussion. Now, this is Professor Craig Cooper-Smith. He is a professor of surgery and a past president of the Society of Critical Care Medicine. He was a leading member of the task force which created a new model for sepsis and its spectrum of conditions. In his public lecture on sepsis, Professor Cooper-Smith noted that the inclusion of SES in the definition of sepsis in the previous international consensuses of 1991 and 2001 was not data-driven or evidence-based. It was solely based on an expert opinion. So it was like, during the conference, one highly respected expert just got up and said, "Look, I strongly believe that sex is necessary to include in the definition of sepsis." And so it was like a trust me bro kind of evidence. Because now the practice of medicine is chiefly evidence-based medicine, they needed to get a data-driven opinion. So you see, in modern clinical medicine, there are about 6 levels of evidence as shown in this diagram. From level 1 through to level 6. Level 1 is more desirable for evidence-based medicine. So according to Professor Craig, the SES model fell at level 5, which is expert opinion, and that is less desirable. This stance was also backed by Professor Quentin Broussard. He is a professor of clinical sciences with expertise in critical care, fluid and electrolyte disorders, and of course, the science of sepsis and septic shock. Now, apart from the fact that the SES inclusion was solely dependent on expert opinion, the Sepsis 3 conference found that the predictive ability of SES for mortality was very low. You see, early recognition of a fatal infection, which essentially is sepsis, is a core rescue achievement for the clinician and his patient. In a study by one Rinaldo Bellomo et al. In the year 2015, about 1 in 8 patients who died from sepsis had a score of 0 when the SES criteria was used. However, fortunately for the patient we presented on, even when we used the SES criteria for her, she still satisfied or fitted into the criteria for sepsis. But according to this study, 1 out of 8 patients who died from sepsis had 0 score when the SES criteria was used. Another problem was that the SES criteria lacked sensitivity and specificity. A study showed that 50% of in-hospital patients developed SES without an evidence of infection. And so, like we established earlier, SES can come from infection or a non-infectious trigger. And this study was by Respire in the year 2015. And so the SES criteria sort of lacked specificity and sensitivity. Lastly, the SES criteria to a large extent was noted to be an appropriate response to an infection. Like when someone has an infection, it is normal for the patient to have fever, an increased white cell count because we need to produce white blood cells to fight the infection, and then the fever can also make the heart beat faster. And so it wasn't thought to be a bad thing, but it was thought to be an appropriate response to an infection. Good. And so these, among other reasons, necessitated the task force to discard or modify, I wanted to say, the definition of sepsis. And so there was a need to discard the old model, and then a new model needed to be brought into being. And so how is sepsis and septic shock defined under this new model? The current definition of sepsis says it is a life-threatening organ dysfunction as a result of a dysregulated host immune response to a focus of infection. The key terms have been written in yellow: life-threatening organ dysfunction, dysregulated host immune response, and then the focus of infection. Now, I must quickly emphasize that this definition is not a unanimous definition, but is one arrived at a consensus. It means majority of clinical or medical societies endorse this definition, but a few think that the CES criteria is still enough to work with as far as the diagnosis and management of sepsis is concerned. For example, an article published by Surviving Sepsis Campaign 2021 has rated CES criteria above this popular new model. And then Center for Medicare and Medicaid Services still support CES. They want to bring CES from the graveyard. And so please take note of the fact that this current definition is not a unanimous definition, but one arrived at a consensus. Very good. And so now, how do we clinically measure the key points in the new definition of sepsis? So how do we measure, for example, life-threatening organ dysfunction as a parameter? Truthfully, there is not a single excellent tool. The scores which were developed in this new model actually predict mortality. And so when those scores are significant, they predict that the infection is potentially fatal. And so they can be used as a proxy for measuring organ dysfunction. And so the various scores we know to measure life-threatening organ dysfunction include SOFA, SOFA. Now, SOFA stands for Sepsis-Related Organ Failure Assessment Score. So we have the SOFA score. Sometimes the S there can mean sequential. So sequential organ failure assessment score or sepsis-related organ failure assessment score. Then we have the qSOFA. So the qSOFA was derived from the SOFA. The Q there stands for quick. And so qSOFA means quick SOFA. Quick sepsis-related organ failure assessment score. Then we have NEWS, NEWS, which stands for National Early Warning Score. Then we have a fourth uncommon one called LODS, LODS, which stands for Logistic Organ Dysfunction Score. Now, among the four, the one used frequently to replace CES is the qSOFA score. So the qSOFA score is the score that has replaced CES in the current definition of sepsis. And we will look at the SOFA score and the qSOFA score briefly in subsequent slides. And so on this slide, let's see the SOFA criteria. Now this is a table illustrating the parameters of the SOFA criteria. We will not go through everything on this table. I just want to highlight the 6 parameters that make up the SOFA assessment criteria. And so we have respirations, the first parameter. So the respiration, you are looking at the partial pressure of oxygen or the fraction of inspired air. Then the next parameter is the coagulation. So you are looking at the platelet count, how low it is. Then you are looking at the liver function. So the liver function, you are interested in the amount of total bilirubin, how high it is. Then you come to the cardiovascular. You are looking at the blood pressure, how low is the blood pressure. Then you are looking at neurologic status. For the neurologic status, it is a GCS you are interested in. How reduced is the GCS? Then lastly, we have the renal function, and we are interested in the creatinine. Now, as you can see, the SOFA criteria is kind of cumbersome. And then for SOFA criteria to be significant, you need to have a score of 2. But because it was cumbersome, there was a need to develop a quick score out of the main SOFA criteria. And so that is how come the qSOFA was birthed. And so please take note of that. Very good. And so on this slide, we want to look at the qSOFA score, the score that has been used to replace SERS. And so this is a diagram we got online to illustrate the qSOFA score. So the qSOFA score is actually made up of 3 parameters. Like you can see, you need an altered mental status, which is calculated using the GCS. So if GCS is less than 15, the patient has a level of, a degree of altered mental status. Then we have the respiratory rate, and so you need a respiratory rate more than or equal to 22 cycles per minute. And then hypotension, you need a systolic blood pressure less than or equal to 100. And we say the patient's qSOFA score is significant if it is 2 or 3, or let me say more than 2 or more. And so if you have any 2 of the 3 parameters present, then the patient in the presence of a focus of infection, then the patient has a higher chance of mortality. And so this patient is likely to have sepsis. And so to summarize everything, qSOFA score is made up of altered mental status, tachypnea with a respiratory rate 22 or more, and hypotension, which is systolic blood pressure. In this sense, systolic blood pressure less than 100 millimeters of mercury. And so if you pick our patient, remember I said we should keep the parameters or the vital signs in our heads. Our patient did not have an altered mental status, but our patient had a respiratory rate of 24 cycles per minute, and that was more than the 22 here. And then for the blood pressure, our patient's presenting blood pressure, the systolic blood pressure was 95 millimeters of mercury, and so the patient had a qSOFA score of 2. And in the presence of the breast infection, this patient had sepsis from breast infection. Good. And so far, we have looked at the current definition of sepsis. Now let's take a look at the current definition of septic shock. Now, the 3rd International Consensus Conference defined septic shock as a subset in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. I know this definition might sound confusing, but all they want to say is that, sepsis, septic shock, multiple organ dysfunction syndrome are a spectrum, okay? And so we say a person has septic shock if there are some circulatory, cellular, and then metabolic changes which are associated with a high risk of mortality more than sepsis. So it means that someone can have sepsis, and if there are certain manifestations which tells you, the clinician, that this patient is likely to die soon compared to a patient with sepsis alone, then you can say that the patient has septic shock. And so how do we clinically recognize this subset in which there is profound circulatory and metabolic derangements that is associated with a much significant mortality rate? And so the clinical recognition is that you first need to identify that the patient has sepsis, and so a patient with a focus of infection plus a significant qSOFA score 2 or 3, so that patient has sepsis. And then the other parameters you need, this is for sepsis alone, then the other parameters you need is a patient who requires vasopressor requirement. Okay, I don't know that if that is the correct English, but a patient who requires vasopressor therapy, I wanted to say, to keep mean arterial pressure above 65 millimeters of mercury in the absence of hypovolemia. What this means is that when a patient starts having a mean arterial pressure less than 65 millimeters of mercury, we first want to push fluid inside to make sure that the reduction in the mean arterial pressure is not because of hypovolemia. Now, if you push the initial fluid requirement inside and then the MAP is still less than 65, it means that there is no hypovolemia. What is causing the MAP less than 65 is not hypovolemia, and so you would need vasopressor requirement. Once this happens, then this patient can be said to be in septic shock, or don't let me say and a patient whose serum lactate is more than 2 millimoles per liter. So if you have this entity, then this patient can be said to be in septic shock. So first, a patient with sepsis, and then two, a patient who has had the initial fluid therapy, but the MAP is still less than 65 millimeters of mercury, and so would require vasopressor requirement or therapy, and then a patient whose serum lactate is more than 2 millimoles per liter. Once you have this clinical entity, then this patient is said to be in septic shock. Now, an additional information, I want to add that neither qSOFA nor the SIRS criteria is fit or is appropriate to use in pregnant women. And so qSOFA and SIRS criteria have been excluded in pregnant women because the physiological changes in pregnancy can give you a false positive parameter, and so we do not use that in pregnant women. So in pregnant women, we use the SOS score, which is the sepsis in obstetric score, or most commonly we use the MEO score, which stands for Modified Obstetric Early Warning Score. So these two scores are used to identify sepsis in pregnant women. We do not use the qSOFA or the SIRS criteria. Now on this slide, let's discuss the pathophysiology of sepsis. Now you see, when there is a local infection or an infection is localized to a certain part of the body, let's say in the case presentation, the woman's breast, there is inflammatory changes in that place, and then the body's host immune response deals with the inflammation at where the problem was, which in this case is the breast. But sepsis occurs when, for some reason, the release of pro-inflammatory mediators in response to a local infection exceeds the boundaries of the local environment, leading to a generalized response. So like I said, there is a breast infection, and then the host immune response is supposed to localize the inflammatory changes in the breast. But for some reason, the pro-inflammatory cytokines, which are going to mediate the the infection in the breast, has exceeded the boundaries of the breast, such that it leads to a generalized response. Once that happens, then sepsis would develop. In the next slide, we will use images to illustrate that. But I want to say that sepsis can be viewed as a malignant intravascular inflammation. And so it is malignant because, one, it is not regulated. So like in the definition we saw, there is a dysregulated host immune response. Those are the features of malignancies. It's not regulated and it can spread. So it spreads from where originally it started to other parts of the body where there are no infectious agents, and so that characterizes the malignant. And the intravascular, because the spread is borne by the blood, and so the blood carries the inflammatory cytokines to other parts of the body to also get inflamed. And then the inflammation is also because the whole process is an inflammation. And so sepsis can be viewed as a malignant intravascular inflammation. Very good. And so on this slide, let us discuss the pathophysiology of sepsis using pictures, and we will use our case presentation to demonstrate this. And so first, there was a microbe, which was a bacterium, and then the microbe infected her breast, and then there was a localized inflammation in the breast. Then what happened was that there was a dysregulated pro-inflammatory cytokine storm, and so the cytokines had gone to the breast to mediate the inflammation, and then because the patient now is going to become septic, what we are saying is that the pro-inflammatory cytokines now get beyond the boundaries of the breast and then spread throughout the body because they are dysregulated, and then they occur as a storm. And so once they occur, initially the inflammation was going on in the breast, but even organs which are not primarily involved in the inflammation start feeling the effects of the inflammation, and that is sepsis. And so you see that the heart, which is not involved, will now start crying because it has been involved in the inflammation now because of the dysregulated pro-inflammatory cytokine storm. The brain will also get involved. You have the lungs crying, you have the liver also involved, the kidneys also involved, and so it becomes a generalized involvement because of a dysregulated host immune response to a focus of infection, which in this case is the breast. And so the pathophysiology of sepsis can be likened to a war that occurs in maybe a certain continent, and then the rest of the world is expecting that the war is contained within that continent. Now, the war can become generalized such that the rest of the world can feel the effects of the war, like high inflation and then high prices of goods and all that. And so that is how sepsis is. There is a localized inflammation, but for some reason there is a dysregulated host immune response such that other organs which are not or which were not primarily involved in the initial process of the inflammation also starts getting involved. So the whole body is thrown into a state of inflammation, and that is sepsis. Now, having established that almost every organ system in the body is affected by sepsis, let's look at the effects on them, beginning with the effects on the cardiovascular system. And so because of the inflammatory changes going on in the myocardium, it causes myocardial depression, and that causes the heart to ineffectively or inefficiently relax and then contract. Because of that, it leads or it contributes to the hypotension. So that is on the cardiac system. And then sepsis also leads to significant derangement in the autoregulation of circulation. So the circulation is regulated in a way that if there is a high blood pressure, the circulation undergoes certain changes to normalize the blood pressure. If there's low blood pressure, the circulation also knows what to do. But because of sepsis, there is a derangement in the autoregulation leading to problems. And then this ultimately leads to hypotension. Then the endothelium in the microcirculation is damaged. So because the endothelium in the microcirculation is damaged, oxygen delivery to various tissues is also impaired, and that leads to the multiple organ dysfunction as a result of ischemia. Why? Because the endothelium is damaged. Then, still on the circulation, there is unresponsiveness to fluid and adrenergic boost. So, despite the fluid you give the patient, especially when the patient is in septic shock, when you give the fluids, because the autoregulation of the circulation is impaired, the body does not respond to the fluid you are giving, and so the blood pressure can never come up and will constantly go down. And then even if you give vasopressors or adrenergic boosts, if the sepsis has badly affected the cardiovascular system, there will still be unresponsiveness, and so the circulation cannot regulate itself and is constantly going down, leading to hypotension and then subsequently death. Good. Now on this slide, let's look at the effects of sepsis on the kidneys, the liver, and the brain. Let's begin with the kidneys. So on the kidneys, there will be acute kidney injury. This acute kidney injury may be as a result of a prerenal cause, and this one is from the hypovolemia that the septic patients come with, or the infection can cause acute tubular necrosis resulting in an intrarenal AKI. So the point is that the AKI can either be prerenal AKI, that is from the hypoperfusion, or from a septic acute tubular necrosis. Then on the liver, there can be an ischemic hepatitis or shock liver, and that may result in jaundice and then bilirubin in urine, called bilirubinuria. Then on the CNS, the cerebritis over there can cause encephalopathy, and so the patient might present with a reduced GCS, the patient might be drowsy, the patient might have seizures, etc. Sometimes on the nervous system, it can also cause peripheral neuropathy. Now let's look at the effects on the pulmonary system or on the respiratory system. Remember, we said that in the cardiovascular system there is endothelial damage, and so the endothelial damage of the pulmonary capillaries can lead to fluid seeping out into the pulmonary interstitium and in the alveoli, and that can cause pulmonary edema. And so this pulmonary edema is a non-cardiogenic pulmonary edema. So this would result in a syndrome called acute respiratory distress syndrome. And I got a chest x-ray from online to show you how the x-ray, the plain chest radiograph of a patient with acute respiratory distress syndrome looks like. This is not always the case, but you see that the lung fields have become hazy, opaque, indicating that there is fluid over every part of the lung, and then that is due to endothelial damage, which has resulted in fluid seeping out into the interstitium and the alveoli, causing this haziness. And this syndrome is called again acute respiratory distress syndrome. Very good. And so we've seen what sepsis is, the pathophysiology, and the effects on other systems. And so here we want to talk about the clinical features of septic patients. How does sepsis present? Now, when it comes to the presentation or the manifestations of sepsis, I like to group them into three major criteria. The first is the non-specific features of inflammation. Once there is an infection, there will be some features of inflammation like fever, etc., which we will look at in a minute. Then the second criteria is the primary organ-specific symptoms. Okay, so where the infection occurred, there are some symptoms that are specific to that organ which would also manifest. So for example, like our patient, apart from having the non-specific features of inflammation, the patient would have some features that are pointing to a breast infection, like the breast pain she came with, etc. Then the third category is the complications of the sepsis. Okay, and so the initial infection was in the breast, but it has become complicated, and so when there is complication, there is multiple organ involvement or multi-organ involvement, and so those would also come with some features. And so the features of sepsis, like I said, can be grouped into three. That is how I want to see it: the non-specific features of inflammation, then the primary organ involved in the sepsis, and then the secondary or the complication that has arisen, as it were, from the sepsis. And so looking at the non-specific inflammation features, we have fever. You know that whenever there is inflammation, there is fever. Then we have chills and rigors. Headaches can also be non-specific. The patient may have malaise. All these are non-specific features of illness or inflammation. Good. And so on this slide, we will look at some primary organ symptoms. Depending on the primary organ which is involved, in addition to the non-specific features, we may have some organ-specific features. And so, if let's say this diagram is actually a picture of the body, so you can have infections in the head, in the chest, in the abdomen, on the legs, etc. And so, if the patient has, say, meningitis, so the patient, in addition to the fever, malaise, anorexia, and all, the patient may come with neck stiffness, photophobia. Then on examination, Koenig's sign, Brzezinski sign would all be positive. So these are a few of the features for meningitis. If the primary organ involvement is pneumonia, so let's say the patient had pneumonia and it will later become sepsis, the patient will first come with chest pain, dyspnea, cough, sputum production, in addition to the non-specific inflammatory features. If you come to the abdomen, we'll just pick one. Let's say the patient came with acute pyelonephritis as the primary organ involvement, and so the patient will come with flank pain and LUTS, which is lower urinary tract symptoms like dysuria, urgency, frequency, and then on examination, the patient may have renal angle tenderness. If the patient came with septic arthritis as the primary organ which was involved, the patient might come with a painful knee swelling. If the patient has cellulitis as the primary involvement or primary organ involvement, the patient would come with a unilateral leg swelling that is painful, that is reddened, etc. If the patient were a female and then comes with a pelvic inflammatory disease, the patient may come with a lower abdominal pain associated with passage of offensive vaginal discharge, in addition to the non-specific features we mentioned earlier. And so look at it like that every organ in the body, when infected, can progress to sepsis. And then this picture, I just showed just 5 types of infections, but almost every bacterial infection can lead to sepsis. And it depends also on the virulence of the organism and then the immune status of the host. Very important and very key. And so from the primary organ involvement, the next clinical feature we need to look at is the complications. And so we can have complications all over the body, beginning from the head, so the CNS. So the patient may come in confused, the patient would have a reduced GCS, or the patient would have seizures. You come to the chest, we have the lungs. So we said that if the sepsis has involved the lungs, it may cause ARDS, which is acute respiratory distress syndrome. So the patient may come with cough, dyspnea, which is difficulty breathing, and then chest signs of consolidation on examination. And so and then desaturation means that the patient will be having low oxygen levels, as evidenced by the pulse oximeter. So the chest signs of consolidation include a reduced chest expansion, the dull percussion notes, reduced air entry, bronchial breath sounds, increased vocal resonance, etc. Then on the cardiovascular system, the patient may come with shock if it has complicated the cardiovascular system. So the patient will come with tachycardia, that is increased pulse, and the pulse, it will be weak and thready, and also the patient will be hypotensive. And remember the effects of on the cardiovascular system we spoke about. Those are the mechanisms that will lead to the tachycardia and then the hypotension. Then it may cause renal complications, and like we said, that would be an AKI. And so the patient may come with oliguria or anuria. Okay, so oliguria is urine output less than 500 mils in a day, and then anuria is no urine at all, or if any urine is produced, less than 100 mils in a day. Then on the liver, it can cause shock liver, which is also ischemic hepatitis. Remember, there is endothelial damage, and so we can reduce the oxygen flow or oxygen supply to the various cells. So the liver can have a shock liver, and that would manifest as jaundice and then yellowish urine. And then on the coagulation system, it can cause disseminated intravascular coagulopathy, abbreviated as DIC, where the patient will start bleeding from various sides. So you may see bleeding patches on the skin. So you may see purpura, ecchymosis, petechiae. The patient may bleed from IV line sites. The patient may bleed from the nose, etc. And so for these patients, what are the relevant investigations to do? And so first, establish that there is an infection. So you do a full blood count, and then you realize that there is an increased white cell count, like in our patient who had a white cell count of 21. Sometimes, instead of having an increased white cell count, you may have a rather reduced white cell count. It may also indicate an infection. Or for especially older people, the white cell count might even be normal. Then the next thing is to investigate the primary focus. Okay, so there is an infection. What is responsible for that infection? So you investigate the primary focus. And so if you are thinking of meningitis, the patient comes with symptoms and then signs of meningitis, you'd have to do a lumbar puncture. If the patient comes with sore throat, odynophagia, things that are pointing to tonsillopharyngitis, you'd have to do a throat swab for culture and sensitivity. If the patient comes with symptoms and signs suggestive of pneumonia, you have to do a plain chest radiograph. So really, the investigations you order should be based on the history given. If the patient comes with clinical features suggesting a urosepsis or the urinary tract as a primary focus of infection, you need to do a urine RE and a urine culture and sensitivity. And then regardless of what the primary focus is, you need to do a blood culture for culture and sensitivity. But note that about 50% of patients would have a culture negative sepsis. It means when they culture their blood, you may not isolate any organism, and then this might be due to the fact that the blood sample taken was not adequate for the microbiology, or it could also be that the organism that is causing the sepsis is not bacterial, it's probably fungal sepsis, or even if it is bacterial, that organism does not grow in blood. And so just keep in mind that the absence of a positive blood culture does not rule out sepsis, because about half of patients with sepsis would have a culture negative sepsis. And so, still on the investigations for the primary organ of involvement, if you are thinking of a pelvic inflammatory disease, then you may want to do an endocervical swab for culture and sensitivity. And if you are thinking of a wound infection, you need to do a wound swab for culture and sensitivity. Then the next step of investigation is to investigate for possible complications. And so you need to do liver tests to see whether there are deranged liver enzymes. And indeed, an elevated bilirubin is a bad prognostic factor. You need to do a blood urea electrolyte and creatinine to assess the renal function. If elevated, if creatinine is elevated, may indicate an acute kidney injury. You need serum lactate because a level more than 2 millimoles per liter indicates a possible septic shock. Then you have coagulation studies, so you want to do your INR, your fibrinogen levels, to see if you are not, or the patient is not in DIC. You want to do arterial blood gases for evidence of metabolic. Very good. And so on this slide, let's summarize the approach to diagnosis. And so, like every clinical condition, you need a clinical history and then a physical exam. Here, you want to establish that there is an infection, and then you find its focus. So you use the qSOFA score, which has 3 parameters, at least 2 parameters plus a clinical evidence of infection based on what you find in the history and then what you find on exam. Then you move to the investigation. So we said for the investigation, you first need to establish that there is an infection and where is the focus of the infection with the various investigative tools at disposal. Then you need to do some diagnostic and prognostic investigations. And so I think I've mentioned this in the establishing the focus of the infection. And so you establish that there's an infection with the full blood count, and then you do some diagnostic investigations, meaning you are finding the focus of the infection, and then some prognostic investigations that can tell you if the survival chance is good or bad. Some of these prognostic investigations actually look for the complications of sepsis. And so this is the simplified approach. In summary, what you need is a history and physical exam, and then use that to establish that there is an infection, find its focus, and then use the qSOFA score. Once the qSOFA score is significant, an infection with its focus plus a significant qSOFA score is equal to sepsis clinically. Then to prove it by investigation, you first establish that there is an infection with full blood count, and then you use some diagnostic tests to establish its focus, and then you do some tests to see whether there are any complications, and some of the tests can give you some prognostic values. That is all we want to see. Now, what is the approach to management of a patient with sepsis? Once we are discussing the approach to management, it means we have some goals of therapy. We have some aims we need to achieve. Now, the first aim you need to achieve is that you should recognize sepsis early. And so early recognition is an essential goal of therapy. Remember, we said that if we recognize it early, the chances that we will save the patients is very high. Then after we have recognized it early, we need to start an early hemodynamic resuscitation. And so we have to save the circulation from being destroyed by sepsis. And so we have to start it early hemodynamic resuscitation. And then the third is early and adequate antibiotic therapy. So we need to start the antibiotic therapy very early, and we need to give it adequately so that we can bring the patient from or out of the state of sepsis. Because remember that sepsis by definition is severe, and so we want to do all these things early, recognize it early, save the hemodynamic system early or circulatory system early, and then start your early and adequate antibiotic therapy. Then next is to control the source. So what is causing the sepsis? Control it. As you are controlling it, then you do your continuous hemodynamic support. Then sometimes if the hemodynamic support is not being maintained by your initial therapy steps, you may have to give corticosteroid therapy. Remember that the sepsis can affect the adrenal gland and cause adrenalitis, and that can cause Addison's crisis, and so you may need corticosteroid therapy. Then you have tight glycemic control. You need to keep the sugars within some tight range, and then provide supportive care including oxygen therapy, analgesia, fluid resuscitation, and then other required supportive measures. And so how do we manage a patient with sepsis? After we've made a diagnosis of sepsis, what do we do? So the first thing is to stabilize the respirations. It's an emergency, so you go through the ABC. And so in stabilizing the respirations, you are concerned about A and B, airway and then breathing. So ensure that the airway is patent, and then ensure the breathing is spontaneous and normal, that the patient would not require any mechanical ventilatory support. And then still on the breathing, you want to make sure that the saturation on room air is somewhere above 94 or 94 and above, I wanted to say, so that if the patient would require some help as far as oxygen support is concerned, you need to do that. Then you need to assess the circulations to see, but you get some venous access and then quickly take samples. But before you do that, you need to assess the circulation, the pulse, and then the blood pressure, the capillary refill time. Okay, then if you check the blood pressure, and then this patient ideally has to be on a cardiac monitor. So if you check the blood pressure, and then the calculated mean arterial pressure is less than 65 millimeters of mercury, then you need to manage the circulation by starting your initial fluid resuscitative therapy. And that many literature agree that you can give a minimum of 30 ml per kg in about 3 to 4 hours. It means if the patient, say, weighs 50 kilograms, you are going to give 1.5 liters of crystalloids, IV crystalloids, in 3 to 4 hours. And so the first thing you do is to assess airway, make sure it's patent, assess breathing, make sure it's spontaneous and normal, and SpO2 is normal. If not normal, start oxygen therapy. Assess the circulation. You're looking at the pulse, the blood pressure, capillary refill time. All these will tell you the volume status of the patient, and particularly about the blood pressure. If you check the blood pressure and its computed mean arterial pressure is less than 65 millimeters of mercury, you need to start your initial fluid resuscitative therapy with IV crystalloids, whether normal saline or Ringer's lactate, and the minimum you can use is actually 30 ml per kg in 3 hours. Now, whilst doing this, you need to make sure that you are not overloading the patient, and so whilst giving this fluid volume in 3 hours, you need to pass a urethral catheter and then monitor the urine output. You need to be regularly listening to the patient's lung bases to make sure that you are not causing pulmonary edema. You also have to be watching the patient's eyes, and then a whole lot. We will discuss this in our next slide. Very good. And so, like I hinted earlier, the initial fluid resuscitation we start if the blood pressure is low is to achieve a mean arterial pressure of at least 65 millimeters of mercury, and so 65 millimeters of mercury and above. Then, like I said, we need to pass a urethral catheter to get an adequate urine output, and so we want a urine output more than 0.5 ml per kg per hour. And then if there is expertise, you need to pass a central line to monitor the central venous pressure, and we want a target of or a target between 8 to 12 millimeters of mercury. It shouldn't go above 12 because that may indicate fluid overload. And so once we start the initial therapy, these are the things we are looking for. Not all facilities can monitor the central venous pressure, but at least the mean arterial pressure and the urine output can be done by every facility. Then after stabilizing the ABC, you quickly start your IV empirical antibiotics. Now when it comes to antibiotics, we have 3 areas. We talk about the timing of administration of the antibiotics and the choice of the antibiotics to use, and then the dosing of the antibiotics. Now, when it comes to the timing, the administration of the antibiotics should start immediately after the blood culture and other relevant investigations have been taken. So just after doing that, we need to start the IV empirical antibiotics as soon as possible, because remember our goals of therapy. One of the goals is to start early and adequate antibiotic therapy. Then we come to the choice of the antibiotics. Now the choice of the antibiotics depends on several factors, including the microbiology data of the facility. Maybe the facility has found out that over the years E. coli is a cause of sepsis, so it is sensitive to this medication, so we start that antibiotic first. Or another factor is to consider the primary focus of infection. If you think that the primary focus of infection is in the urinary tract, then you probably need to start antibiotics which are sensitive against E. coli, because the primary focus of infection will tell us the likely organism responsible for the antibiotic. And also another factor that depends or that determines the choice of antibiotic is the previous antibiotics the patient has been on. And so if the patient was referred from a peripheral facility after having had about 3 days or 3-day course of rocephin or ceftriaxone, then when the patient comes to you, it doesn't make sense to continue the rocephin, because if the rocephin would have helped the patient wouldn't have been referred to your facility. Then the third thing is the dosing of the antibiotics. So in principle, if there are no contraindications, you have to start the maximum dose you can ever give for that particular antibiotic. And so routinely we give, for example, ceftriaxone for as 2 grams daily, but you can give a maximum of 4 grams in the day. So you can give 2 grams BD. Now, if there are no contraindications, you have to start with the highest or the maximum dose you can ever start. Then if the patient starts getting better, you de-escalate. Okay, so that is the principle behind the IV empirical antibiotics. The timing should be early, the choice should be reasonable, and the dosing should be more, or the maximum dose you can ever give. So right after you have started your antibiotic therapy, you need to determine the location of patient care. Where should the patient go? Should the patient be at the triage area? Should the patient be on the main ward, or where should the patient be? So ideally, any patient diagnosed with sepsis should be treated in the ICU. If the facility has the resource, a patient with sepsis should be treated in the intensive care unit because of the chances of mortality associated with sepsis. Then we come to source control. So we need to control the source. So if we think that the source is maybe an IV line or an indwelling catheter, we need to remove all those. If we think that the source is from an abscess, we need to call the surgical team to come and drain the abscess. Because no matter the antibiotics you push in, if the source is still there, the infectious process or the septic process will be going on and on. And so if there is an abscess suspected or confirmed, the surgical team needs to be made aware of. Then if the patient has a necrotic tissue which is infected, like a patient with diabetic foot who has sepsis, the surgical team needs to be called to determine whether or not to do excision of the necrotic tissue. Because remember, sepsis is not only a problem with internal medicine, but a problem with every medical discipline. Then the third the next thing to do is not to leave the patient unmonitored. The patient has to be on continuous monitoring. Okay, so the patient has to be on a cardiac monitor, for which reason the patient needs to be in the ICU or any intensive, a place that we can properly monitor the patient. So you monitor the patient's blood pressure, patient's pulse, patient's saturation on oxygen, the patient's response to the fluid therapy, the patient's temperature, etc. Very good. And so we need continuous hemodynamic support, like I mentioned earlier. So you see, those whose MAP or mean arterial pressure was 65 or was less than 65, we said to start the initial fluid resuscitation. Those who fail the initial fluid resuscitation, it means that after 30 ml per kg of IV crystalloids in the first 3 to 4 hours, by ideally 3 hours, they still have a MAP of less than 65. They should be regarded as having septic shock together with the serum lactate levels. But even without the serum lactate levels, they should be treated as having septic shock. And so for such patients, in addition to the fluids, you need to give them some vasopressor support. So vasopressor therapy. The vasopressor of choice for septic shock, first drug of choice is noradrenaline or norepinephrine. And we can also use vasopressin, dopamine, and in fact we need to start with noradrenaline and then titrate it to the maximum dose. If it doesn't work, we can add on vasopressin, dopamine, etc. Sometimes we need to give inotropic support, and so we need to give dobutamine. And as mentioned earlier on, if the sepsis is so severe to cause adrenalitis or adrenal crisis, we need to start glucocorticoid therapy. And so if after all these the patient's BP is still not responsive, we need to give glucocorticoid therapy. But I must mention that some authorities like UpToDate do not recommend the routine use of glucocorticoids in the management of sepsis. So after doing all these, then you give the patient the necessary supportive care. And so number one, you transfuse the patient if the HB is less than 7 grams per deciliter. So it means in sepsis, if the HB is low but it's not less than 7 grams per deciliter, and the patient is still not symptomatic, you do not transfuse the patient. So you only transfuse if HB is less than 7 grams per deciliter. Then you give drugs for stress ulcer prophylaxis, and so you give omeprazole to prevent stress ulcer. Then DVT thromboprophylaxis with appropriate anticoagulants like Lexine or sodium enoxaparin. You ensure the patient eats adequate nutrition, and then we need an intensive insulin therapy to maintain a serum glucose between 7.7 and 9.9 grams per deciliter. This is from UpToDate. And so, yes, these are the various supportive therapies you can render the patient. And so here I want to share a few of my references for this comprehensive lecture. I used Merck's manual, the chapter on sepsis, and then like I've been referencing for most of the times, I used the third international consensus definition for sepsis and septic shock, Sepsis 3. Then, of course, I made reference to UpToDate, the chapter on sepsis syndromes. Most of the information came from UpToDate. Then we used also Medscape, the topic or the chapter on bacterial sepsis. Then the man whose name I mentioned, I used Professor Craig Cooper-Smith, his public lecture on sepsis. Then we used Davison's Principles of Internal Medicine, the 21st edition. Then also I made reference to Surviving Sepsis Campaigns, the 2012 and 2021 articles. And I want to point that again, Sepsis 3 is the most current meeting as far as a consensus definition for sepsis and septic shock is concerned, Sepsis 3 is the most current meeting or most current conference. Other references I used include Prof. Quentin Broussard's public lecture on sepsis. Then we used the ACCP or the SCCM, the Society for Critical Care Medicine Consensus Conference, definitions for sepsis and organ failure, and the guidelines for the use of innovative therapies. Then I also made reference to Society of Critical Care Medicine, one of the societies which was involved in the task force which drew the current model for the definition of sepsis and septic shock. Then the last reference I would want to mention is the International Health Forum defining sepsis. There were a few other non-documented references I used. And so thank you for staying tuned till this time and listening to this comprehensive lecture. I hope it helped, and I hope it will go a long way to help our patients. Thank you for watching. Please do not forget to share this video, like, subscribe to our channel. So see you in our next lecture, and until then, I want to say bye.